my pleasure to introduce Marianne Sofronas. Marianne is a nurse, ethicist, and anthropologist. She completed an MA in anthropology at the New School for Social Research in New York City, a Master's of Science and PhD in nursing at McGill. She is currently a postdoctoral fellow at the University of Ottawa with the Palliative Care and Nursing Ethics Hub and a faculty lecturer at the Ingram School of Nursing at McGill. Marianne's research is in neuropalliative care, clinical ethics, personhood in illness, clinical and organizational applications of compassionate frameworks, and ethnography with vulnerable populations. Marianne worked clinically for over a decade as a nurse clinician in neurocritical care and as a clinician ethicist at the MUHC. She is the recipient of multiple awards for clinical practice and research, including a postdoctoral fellowship from the CIHR, a doctoral fellowship from the FRQS, and the Richard and Edith Strauss Doctoral Training Award in Clinical Nursing. So please join me in welcoming her.
Thank you. I'm thrilled to be here and to talk about palliative care in the context of neurocognitive disorders. I have no conflicts of interest, and these are my two learning objectives. So first, to describe some challenges in integrating palliative care models in care approaches for patients who are living with neurocognitive disease disorders changes, and to understand how these challenges impact not only the patients and their families, but really a wider range of stakeholders, including clinicians. Here are our competencies, and let's go. What do we mean when we're talking about neurocognitive disorders? Well, there's a lot of literature to describe and to classify them, but they're often referred to under the umbrella term of dementia. And so I'm going to use dementia and neurocognitive disorders interchangeably. We're broadly talking about acquired cognitive disorders that are due to an underlying neurodegenerative process. And the severity could range. It could be mild to severe based on the degree of cognitive decline and the extent to which it interferes with activities of daily living and independence. It's important to note that this is not a normal part of aging, and Alzheimer's disease is the most common cause of dementias, accounting for 60 to 80% of cases. But there's other causes as well, including different types of dementia, vascular dementia, Lewy body, and frontotemporal, and so on. And so the one point that's important here is that while we might think of neurocognitive disorders as a disorder of memory, there's actually a lot more to it. Related to memory are capacities like attention and reasoning and completing tasks and being able to communicate and understand language, both written and verbal, spatial orientation, behavior and mood, and also the ability to maintain relationships. And changes in these realms could really have a devastating impact on patients and their families. Oops, going too fast. The data I'm sharing today is from my doctoral work, which was an ethnography of neuropalliative care, and I'm pulling out specific elements that are pertaining to neurocognitive disorders. My neuropalliative colleagues, Justine Gauthier and Dr. Jeff Hall, they're going to present a little bit later this afternoon, and I wanted to share some parallels with their work, which is that neurologic diseases and neurocognitive disorders are largely incurable and progressive, and this makes palliative care a really important consideration. And because these patients experience changes to the way that they think and communicate and behave and function, these changes really challenge our care practices, including achieving a good death. Okay. So let's look at some numbers in Canada around the burden of disease. Oops. Over 600,000 people are living in Canada with dementia, and these are numbers from 2022. And by 2030, the projections are that there's going to be nearly 1 million people living with dementias, which is a big, big increase. And between 2020 and 2050, projections are that there's going to be 6.3 million people who will develop, live with, and die from dementia. The cost to society is enormous, and the cost to family caregivers is also enormous, estimated at about $7.3 billion in kind of caregiver hours just for informal carers. And it's also, requires a lot more care than caring for older adults that don't have cognitive changes, and it's also very exhausting physical and emotional labor, and a large proportion of caregivers who are taking care of older adults with dementias report caregiver burnout, almost double the amount of burnout that we'll see in caregivers of patients who don't have neurocognitive changes. And so the needs of aging and aged populations really align closely with the goals of palliative care, both in care education and research. And it's no surprising then that palliative care has become a real major focus of the National Institute of Aging at the US National Institutes of Health. So, oops, what happened? Okay. Uh-oh. My apologies. Okay, here we are. I need a second, I mixed up my sheets. Okay, I'm sorry, I think I mixed up my sheets. I just need 1 minute. Okay. I'm going to wing it. I think I'm not going to have a choice. Now I'm sort of perplexed. Where did this go? Oh, I see what happened. Okay. Okay. I'm going to wing this slide. So here I wanted to talk about some of the challenges in palliative care practices for people who are living with neurocognitive disorders. And this is just sort of, I know that there's many more, but this is just to get us started. And one challenge that might come up is that these patients have experienced changes to their cognition and their communication. And in these contexts, this makes us a little bit difficult to provide palliative care, which has been traditionally based on dialogue and reciprocity and meaning making and all of the amazing interventions that we saw throughout the different talks today. A lot of these interventions are actually very difficult for patients who have had changes to their cognition and their communication. And so how then do we have these important conversations? How do we redefine relational engagement? And how do we talk about a good death in this context? The second, another set of challenges, and I saw this a lot in my clinical ethics work, was around issues of capacity and competence. And so when patients have, it doesn't even have to be a diagnosis, just a suspicion of neurocognitive changes, you're often asking questions about whether they have the capacity to consent to care. And what does informed consent look like in these situations? And quite often what we'll see is that even without a formal diagnosis, even without evidence that decision-making is impaired, patients will routinely be excluded from participating in discussions and decisions around their care. And this is something that should concern all of us. If we look at the bioethics literature to try to give us some guidance on how to move forward, we're actually not very well supported. There's not a lot of great answers. And the bioethics literature tends to kind of define decision-making and really put a lot of attention on the decision-making act, which is predicated on this ability to reason and then give us verbal evidence of that reasoning process. And so by focusing so much on that, I think that we end up missing the mark for a lot of these patients. And other issues that come with this is that really by focusing on whether you're capable of making a decision, or not, it really locates the problem or the vulnerability in the person and in their diagnosis. And then it sidesteps a lot of larger factors that might be impeding patients' decision-making capacities. And a lot of that has to do with our own kind of unequal relationships of power in the clinical encounter or on systemic inequities. And so it sidesteps any kind of attention on that, and it really focuses on the patient and on their disability. And so I wanted to look at this from a different perspective. And I wanted to sort of point out that there's why we should look at this link between personhood, neurocognitive disease, and the good death. I just realized the problem, my slides are out of order. I found the problem. Okay, and so I'm not sure how we're gonna do this, but okay, here we go. And so why would we worry about this, this issue, or why would we be worried about the impact of neurocognitive disease on palliative care? And I don't think we need to look much farther than the COVID pandemic and how the elderly living in long-term care were really tragically and disproportionately impacted. And so I wanted to share a quote from one of my research participants who talked about someone in their life who was in long-term care due to dementia and talked about their death. And so they said, he died in the nursing home, but he didn't die of COVID. He died because he was not fed and not hydrated. The providers neglected him because he was the least communicative patient on that floor. This is why personhood is important. The worst thing is that I understand the situation, and these are not bad people. It just happened because it was a crisis. We didn't know what COVID was, and the long-term care residences were not prepared. They weren't getting resources, and he fell in a vat in that situation. And so, sorry, I want to just speak to my slide that's missing, which is that I'm looking at this idea of personhood to kind of look at dementia from a different perspective. And instead of looking at it as a deficit of memory and as a deficit that exists within the person, I wanted to use a definition that was used in the work of psychologist Tom Kitwood. And he defined loss of personhood as the cornerstone of dementia. And for him, personhood was the standing or status bestowed upon one human being by others in the context of relationship and social being. And from this perspective then, cognition and memory changes created barriers to effective relationships with others. And so if we see personhood as something that's relationally embedded, then it follows that it could be sustained or diminished by everyday actions and interactions, including our routines of care. Okay, we're back on track. If we look at the literature on the palliative care needs of people dying of neurologic disease and neurocognitive disorders, we'll see that their needs are actually not very different from those of patients with other terminal illnesses. But patients with end-stage neurologic disease, including dementias, could be at the end stage of their illnesses, at the end stage of their disease process, but they're not imminently dying, and their clinical course and their dying phase doesn't conform to prognostic indicators that we use in other disease groups or in conventional palliative care models. And my colleagues and I called this the poor recognition of the dying, and the dying referring to both the dying patient and the dying process. And in one study that we found in the literature on patients who had dementia or ALS or brain tumors, it showed that they often didn't appear any different in the last few days before death than they did in the several weeks before. And so poor recognition of the dying, the lack of a distinct dying phase, this created widespread prognostic uncertainty. Okay. Great. And so what was the impact of this in the context of neurocognitive disorders? Well, there was some important consequences. Patients were not perceived as being at the end of life, and clinicians really struggled to make sense of ambiguous symptoms of the terminal stages. And this actually was more difficult the longer patients were dependent on others for care. A lot of literature in neuropalliative care actually defines the palliative period as the last 48 to 72 hours of life. And I don't need to tell this crowd that that's not enough time. Failing to recognize when a patient is approaching the end of life led to distress and anxiety for families, and it diminished their trust in healthcare professionals. The belief that palliative care was neither available or applicable to patients with neurocognitive disease meant that very few referrals were made to palliative care or to hospice. And also, patients with dementias received disproportionate amounts of burdensome interventions. And when we say burdensome interventions, it's not always, the CPR, the intubation, those types of burdensome interventions. In my research in acute care settings, what I found is that in order to manage this uncertainty, what a lot of clinicians did was to kind of cobble together these hybrid care plans. And this was care plans that had both curative and palliative orientations. And they thought that they were doing this out of kindness and wanting to be responsive to patient needs and family needs. But unfortunately, a lot of the time there were tensions in these care plans, and they created sort of messy approaches to care. And these messes kind of left everyone, the patients, the families, and the clinicians, feeling distressed. Okay. So with all of these challenges in mind, I wanted to offer two reframes that maybe can offer a way forward in how we think about palliative care approaches for patients with neurocognitive disease. And the first one is that there's no need for intact capacity to recognize and sustain personhood. And the second is that there's no need for prognostic certainty to offer palliative care. Okay, so let's start with the first one. And here, okay. And so for this idea, I lean on the work of anthropologists Roma Chatterjee and Robert Desjardins and Lawrence Cohen, and they questioned whether verbal language is really the only way that we can access the experiences of others. And they caution against assuming that experiences only belong to those who can narrate them. And so, if voices vary with our ability to hear them, then our lack of understanding must be simply due to our inability to listen. And in dementia, as a person loses their memory, they increasingly rely on others to recognize and affirm their personhood. And sadly, as patients lose the ability to recognize, they are no longer granted full recognition by others. In neurocognitive disorders, then, maybe personhood just needs to be pieced together using different means. Maybe we can challenge the assumption that personhood is bound to individual autonomy and that changes to function, cognition, and communication, and the need for increased assistance are seen as a threat to dignity and to quality of life. And my research actually suggested that that was not the case, that it was the social and relational devaluation and imposed vulnerability that came with these functional changes that actually threatened personhood. Canadian bioethicist Françoise Baylis wrote about her mother's experience of living with and dying from dementia, and her mother was Canadian nursing pioneer and civil rights activist Gloria Baylis. As Gloria's disease progressed, Françoise Baylis fought back against comments such as, "This isn't your mother," or "You lost your mother some time ago." Though she saw these as well-meaning attempts at comforting words, she felt that they took away her mother's dignity while also robbing her grief of meaning. And so if we untether these conceptual ties between personhood, autonomy, suffering, and vulnerability, then maybe we can open the door to a more compassionate and inclusive palliative care for people with neurocognitive disorders. Okay. So we'll move on to the second point, that there is no need to offer prognostic certainty, or for prognostic certainty to offer palliative care. And an expectation of certainty impacted the illness experience of patients with neurocognitive disorders, but not in a positive way. And to counter this, people used creative strategies. And one clinician in my study would refer patients to palliative care, document a life expectancy of less than 3 months, and then clarify with her patients. And she would say, "This is what I need to write so you can get the services you need. It's not my fault if you live longer." Only offering palliative care to patients who fit a certain profile just reinforces existing institutional structures and inequities rather than being responsive to patient needs, and it doesn't align with the reality that death and dying, much like most experiences of illness, are actually fraught with uncertainty. In all the literature that I've read, there's not a single downside to the early introduction of palliative care. or of the inclusion of palliative care in multidisciplinary teams for neurodegenerative disease. And a long time frame of dependence and loss of capacity shouldn't exclude patients from receiving palliative care services. So we need to challenge ourselves to collaborate across disciplines and tailor our care to address the needs of patients and families, to restore dignity, to recognize and support personhood, and to strive for a good death. Early discussions of advanced care planning are paramount in any life-limiting disease, and in disorders with an unpredictable course and an unclear dying phase, having these conversations early and often allows us to get to know our patients, to demystify these serious illness conversations, and ensure that patients have a say in what happens to them. And this is particularly important here in the context of dementias, because knowing that cognitive decline will only get worse means that we need a proactive rather than a reactive approach. And this also allows us to see how patients are adapting to their deficits, and it opens up possibilities for us to see that sometimes people can actually live well with their illness, and this perspective is largely missing from this literature. And this is a phenomenon that's sometimes referred to as the disability paradox, this idea that people with serious and persistent disabilities report that they experience good or excellent quality of life, when many outside observers might judge their life as fraught with difficulty and may not be worth living. And on that note, to end this talk, I wanted to share one final quote of what this ongoing conversation can look like in the context of neurocognitive disorders, and this quote actually inspired the title of one of our upcoming papers, We Are Not the Person We Will Be When These Things Happen. So here we go. There was a patient that I followed in my clinic. Every time she came in, she was worse. And I would ask her, is this okay? And every time she said, you know, it is okay, I can do this. But I don't think I would want to live if I were worse. And for 10 years, every time she came back, she would say, this is okay, but I don't know if I would want to live if I were worse. And every time she came in, she was worse. And that's the best example of what we don't know. We're not the person we will be when these things happen, and the person we will be is the one we need to ask. It's an ongoing process. We don't know what is best for that person, what they would want to do. Thank you.
Thank you so much, Marianne. So I'm happy that you're going to stay here, and we'll take questions at the end. But next, I want to present our next speaker, Louise Papillon-Ferland. Louise is a pharmacist, assistant clinical professor in geriatrics in the Faculty of Pharmacy at the Université de Montréal, and clinical professor affiliated with the Chaire Michel Saucier en Santé et Vieillissement. She works at the Institut Universitaire de Gériatrie de Montréal, where she is involved in the ambulatory clinic assessing patients with geriatric syndromes and polypharmacy. She is a member of the regroupement de pharmaciens experts en gériatrie of the Association des pharmaciens des établissements de santé du Québec and of the Health Professionals Committee of the Canadian Medication Appropriateness and Deprescribing Network. Thank you so much for being here with us, and please welcome.
Thank you very much. This is my conflicts of interest. I don't have any commercial conflicts of interest, but I gave talk like today, and sometimes I get paid for them, and get some funds to do some project. So these will be the two learning objectives for today. So I was asked to review the standards of the pharmacological treatment of behavioral and psychological symptoms of dementia, and to illustrate the prescribing principles in the context of palliative care. So these, I should say, were two big objectives. So I think that I will aim for a snapshot of these two subjects since we have 15 minutes together. So I don't expect that we go too much in depth. So These were the competency. So let's start just by clarifying what are we talking about when we talk about BPSD. So BPSD is really a spectrum of disorders. So we need to know what is present in our patients. Sometimes it can be agitation, like restlessness, pacing. It can be more aggressive symptoms, like verbal or physical aggressivity. It could be delusions or hallucinations, so psychotic symptoms. Mood disorders are also a kind of BPSD, so anxiety, depression in dementia, apathy. All the sleep disorder is there also, and disturbance of activity such as, for example, crying, repetitive movements, disinhibition, things like that. And of course, it can be a combination of these symptoms. So why I was asked to talk here is, I think, because it's getting more and more frequent with the course of dementia. So in long-term care, it's almost 90% of the patients that will present with a kind of a BPSD. And over the course of dementia, it's almost all the patients that will have some symptoms of behavioral issues or psychological issues with dementia. It's more frequent with a disease progression, but what we need to remind when we go more towards a palliative approach of dementia is that these behaviors also fluctuate over time. So sometimes they get started on the medications for a certain behavior. It could be agitation, aggressivity, and it doesn't mean that the behavior was present at a point of dementia, that it will still be present a bit later on when the dementia progresses. So as a pharmacist, it means that sometimes we can try to deprescribe to have a bit more, when we aim more quality of life and have a patient be, for example, able to communicate more. And it's for the care of the patient, it has a lot of consequences. Caregiver stress, burden, it's a main cause of nursing home placement. So it's really something that is a big issue in practice. So before talking about pharmacological treatment of BPSD, I just want to maybe clarify what is the place of the medication in BPSD. And this is the ministry algorithm. It's in French, but I will just to guide you through the main principles. I mean, because really the main approach to BPSD, I would not need to be there, is really non-pharmacological. And I see my colleague Vincent, pharmacist, that agrees. So really the main approach to BPSD is to observe the symptoms. We can do some clinical grids to do that, to find the causes. Is there an environmental cause? Is it the caregiver approach that needs to be reviewed? Is it something related to the patient, like a medical condition? It could be constipation. Pain is a very frequent cause of BPSD. And sometimes it can be also just loneliness or need for some affective touch. So it's really, we need really to understand what is the trigger for the BPSD, what are the consequences. But once we have a good description of these, actually we have like BPSD that are considered mild, moderate, or severe. And really the medication just go when it's either moderate, but the non-pharmacological approach didn't work, or for a severe BPSD when there is a danger for the patient or the entourage. Sorry, I'm losing my English at the Friday afternoon. When there is a distress or a danger. So when we assess for BPSD, we need to find a cause, and just to remind you that sometimes medication is a cause of BPSD. I just put a few examples here, like we know some meds will worsen confusion, like anticholinergics, benzo, opioids, but some can be stimulating, like prednisone, or could cause hallucination, like levodopa. But really, I think I could have put the whole list of the CPS there, because what we need to look for is that when we have a behavior change in a patient with dementia, is to look for either a change, a recent medication, because any side effect could trigger some behavioral problem, a medication that could cause constipation, urinary retention, sleep issues. So really, we can consider all the medication list as a possible cause of triggering the BPSD. So also, one thing that is important to mention is where is not the place for medication. And this was a list proposed, and that is pretty much in agreement with all the guidelines, but this one was from the ministry guidelines. So when it's inappropriate behavior from elimination or dressing behavior, like patients that are undressing all the time or things like that, the repetitive crying that is unrelated to some specific symptoms, of course, like pain, verbal disinhibition, wandering, patients that are running away or that having repetitive movements, patients that are putting things in their mouth on a regular basis, that is would be inappropriate, resistant to care or accumulation withdrawal. It's recognized as behavior where the medication is not effective and has more side effects, so we should not aim to treat these behaviors. So when we want to treat some behaviors, these are the usual options that we have. I will focus more on the antipsychotics, then go say a few words about the others a bit later. But just to mention that, of course, they are pretty much all off-label. The risperidone is an exception, but it doesn't change really our choice of treatment. So when we talk about antipsychotics for BPSD, we need to understand for which type of BPSD we can consider antipsychotics. So it's really for severe agitation or psychosis and severe aggressivity. And for these patients, they can be used really when non-pharmacological options have failed and when there is a threat for the patient or the people around. And usually we will prefer in older adults with dementia, the atypicals because of the better side effects profile, so like risperidone, olanzapine, quetiapine, or aripiprazole. And the main geriatric principle is to use the lowest dose as possible and to reassess after 1 to 3 months because sometimes they don't work and we need to remove them. And also because of the risk associated, I will present a bit later. And also to remember that the BPSD fluctuates. So sometimes after 3 months, there is some literature that we can try to deprescribe these medications and be able to some patients won't have a change in the behavior. So, but do they work, the antipsychotics? That's the main question. So I will present you 2 slides that I think for me is the key message. So this one was a study like that's getting old now, but it's really to me the main message. It's the CATI study. So 400 patients approximately with a major neurocognitive disorder, either with psychosis or aggression or agitation, and they were giving either placebo or one type of atypical antipsychotics, and they were looking at how much time it takes to stop one of these, because either it don't work or the patient has side effects. And the main result is that you give a placebo or you give an antipsychotics, and it's the same. It was taking maybe 7-8 weeks for all the groups to be stopped either because it was not effective or because of the side effects. For example, either for quetiapine or placebo, it was getting stopped mostly because it's not effective. And on the other end, the risperidone, olanzapine, and also the quetiapine was getting stopped mainly because of side effects. And so that is to realize that the efficacy is not so great. This is the other image that to me is also talks by itself. It was a meta-analysis, a systematic review from the American Psychiatric Association practice guidelines on BPSD, and you see the types of all the. Does the pointer work here? So you see all different types of antipsychotics for different kinds of symptoms, and actually the effect or the confidence. And you can see very clearly that the effect is either small, very small. For quetiapine here at the middle, actually it was non-significant. So we see antipsychotics used all the time for behavioral and psychological symptoms of dementia, but really the literature to support their efficacy is not that great. But what is also well described is all the side effects of the antipsychotics. So extrapyramidal side effects such as Parkinsonisms. And sometimes I remember a patient we had on the geriatric unit that was treated for delusional thoughts from dementia. And that's a few weeks later, the nurse is, my God, this patient is so agitated, she cannot stand in place. This patient was not agitated. This patient had akathisia and was keeping moving from the antipsychotics. So we need to be careful and monitor the side effect of these molecules. They will also increase the risk of falls and fracture in our patients with dementia. They have, depends of which molecules, but they all have, to a different extent, some anticholinergic properties, like that can worsen cognitive function, then cause constipation, urinary retention. And I remember a study with olanzapine that at some points when they were increasing the dose with olanzapine, it was not effective anymore as a PTSD treatment. And the hypothesis was that at some point we cause too much side effects, and so it triggers other problems in the patient. They also can cause drowsiness. We need to recall that at some point they should be considered as chemical restraints. And what is one of the biggest problem is really the increased stroke and mortality risk that was reported with the antipsychotics. So the number needed to harm varies with the literature, but here was an example of a number needed to harm of between 8 and 31, depending on the molecules, compared to antidepressant at 180 days. So actually, it's recommended that when there is an antipsychotic treatment started, it's with a shared decision, and there should be a consent from the family, so they know that it's a possible risk with this treatment. So the Canadian consensus for the use of antipsychotics and dementia, I mean, they didn't comment on the last version, so the last one on BPSD was from 2012, is that we can use risperidone, olanzapine, and aripiprazole for severe agitation, aggression, or psychosis when there is harm for the patient or others, and of course to consider the significant risks such as cerebrovascular events and mortality. And you understand why they said that there was insufficient evidence about quetiapine because we don't have good literature to support its efficacy. So what about other options? So sometimes we can try antidepressant. So if I go back to the spectrum of BPSD disorders, if we have a patient with depression, I should say that the evidence, the efficacy of antidepressant in dementia is still limited. In practice, we will still try to use it, but the main message is if we reached a pharmacological therapeutic dose and it hasn't helped, is that to remove that molecules, and we will prefer SSRI or SNRI compared to the tricyclic that are quite anticholinergic. In terms of agitation, there is some data with the antidepressants, such as citalopram in the CITAD study. So sometimes when we see that it's one of the class of medication that we can try to spare the antipsychotic need, and it can be another option, especially if we think that there is underlying, for example, anxiety that can trigger agitation, so that can be one of the target patient. For anticonvulsant or mood stabilizer, there was the study with valproic acid that shown that there was no benefit. There was some benefit with carbamazepine, but I mean, for the ones that I'm sure some of you know that molecules, but there is so much side effects on blood dyscrasia and the liver. And when we have older patients with a lot of polypharmacy and we have a medication that, as carbamazepine, has a lot of drug interactions, it's getting so complex that it's really a medication of choice. For the benzo, I put them in parentheses because they can worsen confusion in patients with dementia, so at some point to worsen BPSD, but they can be used as a short term or when it's acute crisis. Sometimes we'll use it also for Parkinson patients, for example, that we cannot give when we need something injectable, that we can't give them Aldol or an antipsychotics that will need to use some benzo, but it's usually some exception case. Regarding cholinesterase inhibitor and memantine, we should see them as a global treatment of the dementia to try to stabilize for a certain period the functionality of the patient and the cognitive state. There was some study, and sometimes they can delay a bit the apparition of the BPSD, but really the study that we have to treat BPSD, they don't really work. So they can be useful for some exception, which is in Lewy body dementia, where they can help like with the apathy or the more psychotic symptoms and we know that Lewy body dementia don't tolerate well the antipsychotics. They will get very rigid. So for these patients, they can be used. So, and one last word on BPSD is that I didn't talk about a sleep disorder in the spectrum of sleep, is that there was this meta-analysis from the Cochrane review, and really for melatonin there was either a little or no effect on sleep parameter, some effect with trazodone, like 40-something minutes, but it's the evidence is quite scarce, which is a 2-week study, and there was some effect with the new molecules like suvorexant and lamborexant, but it was really patients with mild neurocognitive disorder, and there was a lot actually of young patients included in these studies. So very few data available. So that will brings me that I said that any medication could trigger BPSD. So BPSD actually includes global medication optimization, including deprescribing. So what is deprescribing? I put the definition of the Canadian Medication Appropriateness and Deprescribing Network. So it means reducing or stopping, and that's important. It may not be stopped, but just reducing can be a goal of deprescribing, of medications that are no longer beneficial or that may cause harm. And the goal is really to try to focus on maintain and improve quality of life and prevent adverse drug effect. And I like another quote that actually deprescribing is an essential part of good prescribing because it's a cycle of a prescription. So just as I won't go over the list, but you can imagine that we see patients with more than 20 medications with neurocognitive disorders, and at some point the neurocognitive disorders is progressing, getting moderate, severe. So at what point do we reassess? When what do we stop? Is there a change in the target? So how do we do that? So just a global step, we need to have a good review of all medications. Then we need to identify which medication could be targeted for cessation, and I will give you a few examples on the next slide. So, and to determine which ones we can reduce or stop. And this actually, if the third point I put to me is the most important, is we need to do that with the patient and the family because it needs to be a shared decision process. Then we look if we need to stop or if we need to taper progressively, and we monitor if there is any withdrawal events to restart. That's an important thing to tell the patient and the families that if something will recur, then it's an agreement that we restart the medication, and to document as a course. So how do we choose what to reduce or what to stop? Some points are valid for all the patients, like if there is no benefit of a medication or there is an unclear indication, or when medications are potentially inappropriate, like we suspect there is more harms than benefits. For example, it could be antipsychotics for a patient with dementia. If a condition is stable or non-existent, for example, the previous patient was on allopurinol but didn't have gout for many years, maybe lost weight, the diet changed, maybe doesn't need it anymore. And really, the more we get towards palliative care, it's the two last points that to me that change is about preventive drugs, because the life expectancy is getting lower, and actually we may don't get any benefits from some preventive drugs. And the other thing is that this brings with an individualization of treatment goals and objectives, so there is a shift towards more quality of life and not preventive things. So what can we look at when we are looking for some information? What can we look like? There is not a lot of info from the guidelines, but some guidelines will guide us. For example, this was the diabetic guidelines, so and there is some consideration about frailty and end of life, so we can aim for a higher HbA1c. Of course, we can start prescribing some of the diabetic medication if the control is too tight. And also, for example, at the bottom I put it was the American guidelines about statin prevention that were considering stopping the statin. So it's quite rare that we see in the statin guidelines that we have the right to stop it, but it's getting there now. Another example is the stop-frail criteria. So the stop-frail were designed for patients with a short life expectancy, people aged 65 and older, either with significant loss of autonomy in ADLs or severe chronic illness or terminal illness, so patients with severe dementia, an irreversible stage of frailty, and and also that the team think that they would not be surprised if the patient passed away within the next 12 months. And these are, I just put a few examples of which medication class we could consider to prescribe when we are more in this palliative periods, like biphosphonates, statins, calcium supplements, have lower target for, actually less strict target for antihypertensive, anti-diabetic, etc. So there is also some tools that exist to help us. This is an example of the cholinesterase inhibitor and memantine guidelines that was published. So for people with actually very severe end-stage dementia, how to deprescribe, what to address, what to look for when we stop it, if there is recurrence of symptoms, is it a withdrawal, was there something hidden, should we restart? So it's also in the guideline. And I put some resources. I guess we will have the slides after. Yeah, good. So this is at the end of my talk. So just I won't go over all the case, but of course for these patients, the more we are getting towards severe dementia, there is a lot of antihypertensive probably that could be reassessed because we will aim for higher blood pressure. The same for the diabetes. Perhaps the statin was a primary prevention. At some points, we'll reassess the cholinesterase inhibitor if the dementia is getting very severe and we don't think there is any benefit. I mean, maybe there is a medication like pregabalin that we don't know anymore why it was started, that was not required anymore. Calcium, probably at some point we can stop for sure. So you see that but we'll do this one by one. And of course, it's a complex process that's much longer than my little snapshot for today. So thank you.
Thank you. Thank you to both of you for those excellent talks. We only have a couple of minutes for questions. I have one on the chat, so I will ask it. And I think, Louise, it would be for you. Is there any evidence for use of medical cannabis for neurocognitive disorders?
So it's not in the standards that is recommended. I've seen some data of cannabis for BPSD. I mean, I've seen some, like there was a Cochrane review actually on this that says that there was not enough like good data to recommend or to say it was effective or not. When I was looking, there is some observational data about cannabis and agitation in dementia. I've seen some small randomized control trials, like some with THC that were not so effective. I've seen another one with a small study with cannabidiol that was helping agitation, but all patients were also more likely to be sedated and have hallucinations and memory impairment. So, I mean, there is also other ongoing trials, so we'll see. But I think for now the key message is to know, like, does it help the symptoms enough with not too much side effects, and that will be an individual trial, of course, and that because we don't want at the end a bit like antipsychotics, it's not a chemical restraint. If it's really helping the agitation by getting the edge of some symptoms without causing side effects, then I think it's reasonable. But we don't have like the good data to recommend for now.
Excellent. Thank you so much. Do we have any other questions?
Thank you for tolerating all my questions. It's on the topic of chemical restraints. And this is something which unfortunately we can't avoid, especially in the hospital environment where, many individuals have to come at the end of life and who have BPSD, they may have, on top of BPSD, they may have psychiatric disorders, and individuals very frequently are already deteriorating and they're already a very high fall risk, very high wandering risk, and may also be violent. And so I think most of us who have used a lot of these agents for patients, in fact, they have been far more due to the need for restraints, either due to the absence of caregivers at the bedside, or because caregivers could not actually control their loved ones during those final phases. Any comments to say about that?
Maybe the only comments is the stats of antipsychotics that I've raised with the pandemic, and that's one of the best signs that with isolating and have caregiver that cannot take care of the patient properly, that's one of the reasons why the antipsychotics stats were up. The other thing is that maybe to comment on the long-term care, there is the what we call it's the Upper Steps project. It's like a ministerial program of antipsychotics, prescribing and actually global medication optimization. But there is actually training going over to promote non-pharmacological approaches to be able to have less use of these chemical restraints, because it's the stats in Quebec were actually higher than other province, and so yes, and I mean we could do an ethical debate, and maybe is it less expensive than have more resources? Of course, we want the best care for our patient. The medication should not be the solution, and we should promote best care and advocate for that.
So perhaps we'll have one last question just because of the time, but it's related, I think, to what we were just discussing. So someone in the chat asks, when do medications to relieve agitation at the end of life become chemical restraints?
I mean, I think...
Sorry, before you begin, it would be really interesting as well, not to put you on the spot, Marianne, but from your lens, if you have a comment to that question as well, I think that would be really interesting to hear.
Mm-hmm. I think it goes back to the first indication of this medication, does it seem to be distress? Because if we are there is agitation, but like that seems to be distressing, or like so yes, they may be considered as chemical restraint, but if we feel that we are in my perspective, that it still helps to relieve some of the distress and calming. I mean, I think it's maybe, I don't have a good answer. I mean, but I don't think there is perfect answer for that, but I think that may be one way to.
Thank you. Marianne, maybe go to the podium so people can see you as well.
Yeah, I think that's a great question, and it becomes ethical and complex. And it's nice because it kind of ties together our two topics. I think we have to really look at what our intention is when we're using these medications, and if it's to relieve suffering or whether it's to actually with a restraint purpose in mind, And so I know that there's not easy answers, but and it shouldn't replace care, but there's certainly room maybe for both, and to really reflect on the intention and on the goals of using that therapy.
Thank you. Thank you very much to both of you. I'm just going to run up. So thank you very much. to both of you for your excellent talks and for the participation of the group with your questions. I think, all of these talks, I think, could extend for a really long time. So in some ways, I feel we're just touching on some of these ideas, but hopefully during the very short break that we're going to have next with coffee and cookies, which is fortunately in the same room as we are now. So go, grab your coffee, and come back quickly, because we have more. So we'll start back in like a few minutes. Do your evaluations.